Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of FFS-For Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. You are listening to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and today we're talking about how do you know when it's time for IVF. I want to start by saying I'm so thankful for all of your support on this podcast and on all of my other endeavors. This podcast exists completely for you. So thank you for listening, sharing, supporting, calling and asking questions, leaving your questions, and all of the above. A few housekeeping items before we dive into the podcast. Number one is that my very favorite episodes are voicemail episodes. We have another one being recorded very soon. So call and leave your voicemail at the As a Woman voicemail. That's 657-229-3672. Again, that is 657-229-3672. Every episode, we also answer questions at the end of the episode. This is our For Fertility's Sake segment, and those questions you can ask over on Instagram on Monday. So every Monday at nataliecrawfordmd, put your question in the question box, and some of those questions will be answered there, some will be answered here on the podcast, and some will be answered in the weekly newsletter. We really revamped the newsletter. It has recipes, updates, fertility in the news, answering Q&A. We even have a new segment. So if you're a newsletter subscriber, you're invested in the fertility world, I promise it's not spam. You can go to the website nataliecrawfordmd.com/newsletter. And then while you're on the website, you should check out a couple of other things. We do have two courses. One is the Enhance Your Natural Fertility course. This is my favorite course, my bread and butter project, talking a lot about your body and your fertility and your lifestyle. This course comes with a Facebook group, which I help answer questions in, and we do Q&A calls. There's also an add-on or a standalone offer for IVF if you really want to dive into the nitty-gritty of IVF protocols. I see these questions so often. What's the difference in this and that? And even on female physician groups, there's so much confusion about protocols. So if you want to learn more about them, the IVF guide is for you. And my recommendation would be to get both, because then you're really covering everything. But also on the website, you can search the resources section. On the resources section, you're going to find a search bar. So you can type in IVF or PCOS or egg freezing and see all the content I've recorded about that topic. So that's a nice way if you're looking for something to try to find it. Recently, I was on the Diary of a CEO podcast with Stephen Bartlett. He's amazing. It's a really great episode, talking very comprehensively about fertility and your health, and I recommend you go give that a listen if you haven't. And I also just want to say thank you. Last week I announced my book deal with Penguin Random House. I have a book called Balancing Act coming out, and it is a book I have been trying to get to you for years and years. So I'm so excited for all your love and support. It's really amazing to see a dream come true, especially when you've heard no so many times. I will be talking about the process soon, getting a book deal and what this has been like, because it's not been a linear path. But I just want to say thank you so much. You will see information about pre-ordering soon. And more than anything, thank you for supporting me, but also for showing people that we care about our bodies, our health, our hormones, and that women's health is worth having the discussion about. So thank you so much. All right, friends. Well, thank you so much for listening to all the housekeeping. We are going to dive in with some of these IVF questions and thinking about how do you know if it's time for IVF? The short answer is that this is going to be highly dependent on your age, your goals, the full big picture. But there are some universal truths and some things that I find that people are really not aware of. I see patients every single day who will sit here and tell me, I don't want to do IVF. And I get it. I totally understand. But sometimes we have to step back away from where we are in the moment and think about the very big picture. So we're going to run through a few different scenarios and some guiding principles that I have and what the literature shows us. Because more than anything, I love data. I love evidence-based medicine. So remember that when it comes to IVF, what we're trying to do is get 1 month's group of eggs all to grow, take those eggs out of the body, fertilize them in the lab, and then allow embryos to grow. Those embryos can then be genetically tested, frozen, saved, and then we can go and transfer one. One huge thing that people don't think about when we think about IVF is that there's a couple big goals and a few big problems that we are treating all at the same time. And to be fair, I think sometimes fertility doctors don't explain this to the best of their ability. All right, so number one, and probably one of the biggest reasons, is age. As you get older, it's harder to get pregnant. Now, this is not because you're out of eggs. Yes, it's an important component of the puzzle, but why is age so impactful if you still have eggs? It's really because your body, just like my body, absorbs the wear and tear of our entire life. Everything we're exposed to, we absorb, it adds up, and we develop inflammation, and our proteins, our cells start to accumulate damage. That's just normal. I have back pain, I have wrinkles. This just happens as we get older. The same thing is happening inside our eggs, and we call this egg quality, but really what we mean for the most part is genetic normalcy. You may not know that your chromosomes are inside your body. Inside your egg, they're held in a very specific stage of cell division called meiosis. And in this stage of cell division, they're highly vulnerable because they're held in the perfect spot by these meiotic proteins that are susceptible to inflammation. I always use the analogy, imagine I have a line of kindergartners and now I've asked them to stand in line for 39 years. Somebody's going to get out of line. And that's what's happening with your chromosomes. So this is a huge reason why it's just harder to get pregnant as you get older. If you're trying to get pregnant for the first time and you're age 30, you're going to have about a 20% chance of pregnancy per month. If you're now 35, that number is going to drop. It's going to be closer to 10 to 12%. If you're 38, closer to 5%. If you're 40, closer to 3%. Now, these are monthly rates in somebody who is ovulating and trying to get pregnant. None of these numbers are zero. Yes, your best friend's mom, your sister, somebody else has gotten pregnant at these ages. If you're trying to grow your family for the first time, those numbers do not inspire confidence, and they may not be the smartest plan. This is why, if you're not pregnant after 6 months when you're 35, we want a full evaluation, and really immediately, or 3 months of trying at 40. What's really interesting is what is limiting you here is not being out of eggs. It is the fact that a lot of the eggs that you have, the majority of them, are no longer genetically normal. At age 35, it's about half and half. At age 40, it's going to be closer to about 20 to 25% normal. This is what is driving these numbers to be really low. Remember, even at your peak fertility, 24 years old, it's about a 25% chance per month. So humans are not efficient at reproducing. That said, it's important to understand these numbers if you are planning your family, waiting, or this is the time. You weren't purposely waiting, but now is your chance, but you'd like to have more than one kid. When we look at unexplained infertility, which is really insightful because unexplained infertility, well, I have a lot to say about it, but we're going to start with the definition is that you've not been able to get pregnant. And when we test, everything that we test is normal. So you ovulate, the sperm is fine, your fallopian tubes are open, the inside of your uterine cavity is normal. And unexplained infertility, even if you're in the young age group, even if you're 30, now you've made it a year of trying to get pregnant and you haven't, your odds of conceiving drop to 4 to 5% per month. And if it's been 2 years of trying, now that number is 2 to 3% per month. So a lot of times I see people think, oh, I'm not old, so I don't need IVF. But even if you're young, that percent that it's going to happen when all your testing is normal just drops, it becomes low. Now, looking at unexplained infertility, being younger is a better prognosis. And so it doesn't mean you won't get pregnant. And a lot of people will if they keep on trying. This is where we've got to really think about your family. Because if you want 4 kids and you're 34, you may not have the 5 years it might take you to see that positive pregnancy. And that sucks. Whole lot. But it's important for you to understand the facts so that you can make good decisions. There's also this idea that lesser aggressive treatment like IUI or ovulation induction like Clomid will be highly effective. And those things can be effective in certain situations. If you don't ovulate, helping you ovulate can bring your fertility rates back up to your age-related norm. If you don't have sperm and you're using donor sperm, doing an IUI can get you to your age-related chance of pregnancy. Or if there's some mild sperm abnormalities, sometimes doing an IUI can help that out as well. But when it comes to unexplained infertility, either of those treatments alone really does not move the needle. And isn't that fascinating? What does help a little bit is combining the two. So ovulation induction, and specifically ovulating more than one egg, combined with an IUI, does bring your pregnancy rate closer to 8 to 10%. It's still less than 10% per month, and there's still an age-related determination here. But we're not getting to our age-related rate. I'm going to say it's going to get you to about half of what your age-related rate is. So we're improving the odds, but we're still limited that not all your eggs are genetically normal. And in fact, when you're 38, cost-effective analysis, looking at doing IUI, up to 3 IUIs, and then IVF, which is a ovulation induction IUI treatment, or IVF straight away for women who are 38 and older with unexplained infertility. Going right to IVF got you pregnant faster and saved you money because the odds of those IUIs working were so low that most people spent more money before they even got to IVF. Another thing that's really important is to think about what is getting you to infertility. So maybe it's age, maybe you just got started late, and we just know we have more genetic abnormality. Giving more than one egg a chance to be fertilized, to do genetic testing, can be game-changing. Maybe it is unexplained infertility, which we just reviewed. Maybe it's inflammation or autoimmune disease, which can present in a lot of different ways. Can present with infertility. I see it a lot with recurrent pregnancy loss. And sometimes you have a known diagnosis and sometimes you don't. But this is a scenario where I think we're not talking about IVF enough, because if you're ovulating and you're getting pregnant, specifically recurrent pregnancy loss, but you're losing these pregnancies one after another, especially, I saw a patient recently who'd had many, many losses and had DNCs for a lot of them. So that's a surgical procedure where we go in and we take out the pregnancy. One of the advantages is you can then test that for genetics. And she had had many pregnancy losses of genetically normal babies. And that is so hard because we hear people say, oh, the top cause of pregnancy loss is genetic abnormality. But now you're falling into the camp of normal pregnancies that you're losing, even though you can get pregnant. And I know it's a mind game. Egg and sperm are meat in your body, but it's not working out. We've got to change your environment. And what's really interesting and what I don't think we talk about enough is that IVF allows us to profoundly change your body. Inflammation is really prevalent in the world. It's really prevalent in disease states. It's probably the origin for many of our reproductive diseases. Inflammation is the hallmark for most autoimmune disease. And we know autoimmune disease rates are rising as well. And we know people with unexplained infertility, many of them, in my opinion, will be diagnosed with an autoimmune disease later in life, much like I was. But inflammation is also so important when it comes to implantation, ovulation, the entire process of reproduction. So there's a balance of good inflammation that is an important and necessary part of the ovulatory implantation process, and harmful inflammation that is toxic to such things. And if we feel like we have a toxic environment, for lack of a better word, because you have chronic inflammation, if I go and take medication to treat the inflammation, many of these medications are going to impair ovulation or implantation. Did you know that NSAIDs, the non-steroidal anti-inflammatory, Motrin, ibuprofen, Advil, naproxen, Aleve, those can prevent you from ovulating? 75% decrease in ovulation if you're taking naproxen. So we can't go and treat this inflammation, yet expect to get pregnant. But with IVF, I can grow more than one egg, so I'm improving my numbers. I can take those eggs out of the body. I can fertilize them in the lab, so if there is a fertilization issue, can overcome that. I can grow the embryos in a non-toxic environment. There's no inflammation in the lab. The pH is perfect. The temperature is perfect. And then I can do genetic testing of the embryo. So I'm optimizing the embryo environment. But even more importantly is I can come in now and treat your inflammation. Maybe I think there's endometriosis. Maybe I can treat you with a Lupron. And I can change your environment and grow the lining because I don't need you to ovulate now. I already have the embryos. I don't need you to ovulate. I can now come in and give you the medication needed and grow the lining and put an embryo back in. And I have changed the environment of one, the early embryo development when that embryo is so susceptible, and two, the environment of which I put the embryo back inside. So we don't talk about the fact that people with autoimmune disease have a higher rate of infertility and recurrent pregnancy loss. We don't talk about if you have endometriosis and you get diagnosed with stage 3 or 4 disease, your chance of conceiving without IVF is 1 to 2%. And going to surgery in these circumstances and having the endo resected is not changing that outcome by this point. The chronic inflammation is so much. So we act like IVF is the answer. And it is the answer a lot of times. But I think it's so important for us to have the discussion about why it's helpful in this scenario, why it might be helpful for you. So we have age, we have unexplained infertility, we have number of kids you want, we have environment, chronic inflammation or autoimmune disease or endometriosis. We also see low ovarian reserve. Now, this is an interesting category because I even was trained in the camp of, well, if you have a low egg count, that doesn't cause infertility because you have the same rate of fecundability as your age-related norms until you get to the infertile stage. And I've counseled patients on that for many, many years. But you have less time to grow your family, and you're going to have a lower rate of success per cycle of IVF because I'm going to get less eggs. So intervening with IVF is going to be important sooner versus later. I want to do that when you have more eggs versus fewer eggs, because we all remember that IVF success, the two variables that impact it the most are number of eggs you have and your age. But friends, my favorite question is why? Why do you have a low egg count? Maybe it's because you lost one of your ovaries. You had ovarian torsion, had a big cyst, lost an ovary. That's not a big deal, right? That does make sense that you have a lower egg count, and I don't expect that to necessarily impact your fertility. Or maybe it's chromosomal, you carry Fragile X. But what if it is autoimmune or inflammatory? What if it's that undiagnosed autoimmune disease that's causing your diminished ovarian reserve? Then we actually think you're going to have a higher chance of infertility, and now you have less eggs and a higher chance of needing IVF. And the sooner we jump to that camp is going to be important. With low ovarian reserve, my thoughts are, how many eggs do you have? How many kids do you want? Why do we think you have low reserve? Are you older and this is a normal but low reserve for your age? Or are you young? And specifically in my young patients, having a really strong conversation about saving some embryos for the future, thinking about environmentally what could be causing this. Another thing to think about is recurrent pregnancy loss. And this has been debated for a long time. And this is another scenario where it is, why do we think you're having recurrent loss? An unexplained recurrent loss to me is different than a known cause. So part of your recurrent pregnancy loss evaluation is going to include clotting diseases. Maybe you have clotting disorder. Maybe you have autoimmune disease. Maybe you have a uterine septum. These different causes are going to have different etiologies or things we can do about them. So if you have a clotting disorder, just trying to get pregnant again and treating you with blood thinners makes a lot of sense. If you have a uterine septum, resecting the septum and then working to get you pregnant makes sense. But if we think the thing that's causing the pregnancy loss could be contributed to making it harder, could be autoimmunity, diabetes, endometriosis, any of those environmental factors are going to fall back into the environmental game. And the other big cause is going to be age. If we're having recurrent pregnancy loss because we are older, we need to not let our body just randomly pick the egg each month. It's time to push more of them through, be able to test them, find the normal embryo, and put that one back. I also don't see enough people talk about your uterus. You have this one precious uterus, and it can get damaged, and it can be really hard for your uterus to heal. It can have scar tissue inside, and it can develop something called Asherman syndrome. And every fertility doctor will tell you, we hate it. We hate it. It's tough. You do not always know if you can fix it. This is where the uterus actually has layers. So you have the endometrium that you bleed off, but there's actually a basal layer of that endometrium right beneath what you bleed. And those have the regenerative cells that help grow the endometrium every month. And when those regenerative cells have been damaged and you now have scarring in the uterus, this is mostly from surgery, especially in emergent, infective, or hemorrhaging situations, postpartum bleeding, an infected abortion, postpartum placenta that didn't get removed, having a lot of bleeding with a DNC procedure, having a big fibroid removed. These different scenarios can sometimes damage that basal layer of the endometrium, and then what we see is scar tissue develop. And that scar tissue might be something that we can't fix. The more uterine surgery, the more DNCs you've had, the more we're risking with your uterus. And so especially if you've had recurrent pregnancy loss and you've had a lot of DNCs, like my patient I was talking about earlier, I told her, I am nervous that even though you're getting pregnant naturally, we're not changing your environment at all. And the same thing is just going to happen. What's the definition of crazy? Doing the same thing over and over and expecting a different outcome. And at some point, your uterus is not going to recover from this surgery as well as we want it to. And then the answer is had for us. We can no longer try. We can't put any embryos inside now. Time has passed. So when our uterus becomes a player, often this is scarring. This also could be a uterine birth defect. Going to IVF sooner can make a ton of sense. And then we also have carrying genetic diseases. And sometimes we talk about being co-carriers for silent diseases like cystic fibrosis or spinal muscular atrophy. You can do IVF specifically for those genetics to make sure your child doesn't have that really severe or deadly disease. But you can also do IVF if you're a carrier for a disease in your family. So an autosomal dominant carrier disease like Huntington's disease, such as BRCA mutation. There are autodom diseases that you can carry that you can prevent your children from having to experience that. And a good friend of mine is a pediatric critical care doctor, Anita Patel, and she's been very open about the fact that her husband carries BRCA. And they didn't even know. We were having one conversation where they were talking about maybe they wouldn't have kids. And so I said, well, no, you're going to have kids. You can do IVF and we can genetic test for BRCA and make sure your child doesn't have to deal with that. And that was something she didn't even know was on the list of possibilities. And this brings up the point that you often know if an autosomal dominant disease runs in your family because people are affected by it, about 50%. But a lot of those silent carrier diseases people don't know about. So I recommend genetic carrier screening, both partners, for everybody who's struggling to conceive, because you might not have the reproductive longevity to have a pregnancy and carry it to term with a baby that's terminally ill and then recover and get pregnant again. Maybe you do, but not everybody does. And so we want to make sure that we have all the data and all the pieces of the puzzle. Same thing with genetics, can be a balanced translocation. You can have a genetic cause of your recurrent pregnancy loss. And so doing IVF for those genetics can be so advantageous. So when it comes to if it's time for IVF, a lot of this boils down to why you're in this position. So we have kind of flat reasons. Well, your tubes are blocked, or you don't have tubes. You have genetic disease that you're trying to prevent passing on. But then we have recurrent pregnancy loss, uterine issues, age, number of kids you want, length of time you've been trying, your own body's internal environment, or endometriosis or autoimmune disease. And a lot of these are really personal questions that people don't even always ask you. So I'm going to go back to episode 1 and say, what is your goal? And I know that when patients see me, they often say, I just want to have one healthy baby. I get it. I've been there. But if you get to control things, like what does it look like for you? How many kids do you have? How old are you? What data do we know? What data can we get? How can we make this decision? Oftentimes, people are going to IVF faster than they think because the lesser aggressive treatment is not effective for everybody. And in the scheme of life, trying to help you grow the family you want is a huge goal of mine. All right, friends, well, I hope that helped answer some questions. I'm doing an IVF Q&A coming up soon. So the voicemail, 657-229-3672. Again, 657-229-3672. Again, we love to answer your fertility questions, so you can also ask those on Instagram at nataliecrawfordmd every single Monday. Some questions will be answered here, some will be answered on Instagram, and some will be answered on the newsletter. You can sign up for the newsletter at nataliecrawfordmd.com/newsletter. And now we're going to dive in, answering some of your fertility questions. I'm doing IVF and my body is not responding to the medications to stop me from ovulating. Is this common or normal? So when you're doing IVF, it's important to understand that often I believe we get a best result when we do suppression and then stimulation. So the suppression is where we're trying to starve the eggs of FSH. FSH is follicle stimulating hormone, and that's the hormone that comes from the pituitary gland that gets a follicle to grow. Normally, there's a perfect balance between the brain and the ovary to get just enough FSH to get one egg to grow. But in IVF, we often want to starve them all so all eggs are hungry. The analogy I like to use for this is to imagine that ovulation is like a nest of baby birds. And normally, mommy bird brings in one worm, and the biggest bully bird is going to push the others out of the way and then going to grow to be the biggest. If I starve all the birds and there is no big bully bird, everybody's hungry. Then I bring in a tray of worms every single day. Now I have enough food for all the birds to grow at the same pace. And that's a good explanation of what we're trying to do with IVF. However, suppression can be really different. It can depend on you, your medical circumstance, your age, your AMH, and the different options are anything that can stop the body from sending out FSH. Birth control, estrogen, progesterone, testosterone, ovulation blockers, and Lupron, which is a GnRH agonist. These medications all work differently, but essentially they all stop FSH from being released, and they work in different amounts, and not everybody is going to respond to each one. Think about birth control pills. Even amongst birth control pills, there's a lot of different types and different estrogen doses. And we've all heard of somebody getting pregnant on the pill, meaning they ovulated through that estrogen wasn't a strong enough suppression. There is a delicate balance between over-suppressing and under-suppressing you. And this is why we even do a baseline ultrasound in IVF. If you do a suppression, you're going to come in for a baseline, and if you're ovulating through, then we know you didn't respond to that one and we need to regroup or change the dose. There is some trial and error to any good IVF cycle. If your clinic says this is the protocol, the only protocol we ever do, that to me is just a huge, huge red flag. All right, the next question is we are doing IVF to avoid passing on a genetic disease. We're really not ready to start yet. But when should we? We want 4 kids. So this is an interesting question. And the truth is, you should probably do IVF even though you're not ready to get pregnant. Because when it comes to genetics, you're going to lose so many more. Remember that not every egg is going to fertilize or become an embryo or be genetically normal just based on your age. And then we have to add in the genetic disease and its prevalence. Let's pretend you are 30 and you want to have 4 kids. I need 2 to 3 normal embryos per child you want to have, which means at a minimum, I want 8 embryos in the freezer. Success rate from transferring one single embryo is a 65% chance of live birth. Cumulatively after 2, 88%. After 3, 95%. So for real, I want 8 to 10 normal embryos. If you are 30 and I get 20 eggs, which would be a very nice cycle, I would then expect 75% fertilization, let's say 16, half to make it to a testable embryo, that's 8. Based on your age, even if I'm optimistic, let's say I got 6 of them, that could be genetically normal. But if we're doing this for BRCA, I'm going to lose half for the BRCA gene, and that would be 3. And anybody who's done IVF for genetic reasons will tell you that this overlap of what's normal and what has the gene can be wild. It's so much harder. You're going to need 2 or 3 times as many cycles as you think you are. So this one cycle might get you 1 child with 3 normal embryos, and you want 4 kids. So because IVF is determined by how young you are and how many kids you want, this is a great example of it's time to do IVF now, even though you don't want the kids to the future, because you know you have a reason to. You're the youngest you're going to be. You have the most eggs you're going to have, and the genetic number is going to hurt you more than you think. So it's better to be prepared and do this ahead of time and not be behind the game. All right, and the last question is, do I need an HSG after having an ectopic pregnancy treated with methotrexate? Remember, an ectopic pregnancy is a tubal pregnancy. Methotrexate is an injectable medication. It's a chemotherapy that's a folic acid antagonist, so it stops an important step in cell division. Therefore, it stops the growth of that developing pregnancy. If you are wanting to still get pregnant after this ectopic pregnancy, I absolutely recommend that patients get an HSG test to see if 1, is the fallopian tube open? 2, how is the other tube? 3, do you have a dilated fallopian tube? A dilated fallopian tube is a hydrosalpinx. That's where the tube has been damaged. It's not necessarily blocked at that spot, but it fills up with liquid that can be toxic to a potential pregnancy. So if you're trying to still get pregnant or want to be pregnant, if you're not at the step where you're moving on to IVF, then I do recommend an HSG, which is a hysterosalpingogram, the X-ray dye test to check your eggs. Hope these answers were helpful, and I hope you enjoyed this episode. Again, please call in and leave your questions at 657-229-3672. That's again 657-229-3672. You can also leave your questions on Instagram every Monday at nataliecrawfordmd. Some will be answered here, some on Instagram, and some in the newsletter. Sign up for the newsletter at nataliecrawfordmd.com/newsletter. Thanks, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.